sent around. So tonight, we're excited to have Warner Slack. Dr. Slack is a professor of medicine at Medical School. He's a member of the Division of Clinical Informatics at the Department of Medicine and the Department of Psychiatry at Beth Israel Deaconess Medical Center here in Boston. Dr. Slack received his bachelor's degree from Princeton University, his medical degree from Columbia College of Physicians and Surgeons, and his medical internship and residency training in neurology at the University of Wisconsin. As a full professor of the Harvard Medical School, he also received an honorary master's degree from the school. Over the past 40 years, he's focused his research on the use of computers to improve communication in the field of medicine and to empower both patients and doctors for better health care. From 1989 to 1998, he was also the editor-in-chief of the journal called MD Computing. He's published well over 100 articles in a variety of computing and medicine and patient interaction, and as well as written a book, which is kind of a theme for this presentation. So we're really excited to have him. Join me in a welcome of applause for Dr. Warner Slack.
Can I be heard in the back?
Excellent.
Well, I thought since there's such a delicious array of food here and many of you have partaken, I thought it would be, one of my obligations is to combat postprandial somnolence. And you know, the old definition of the Harvard professor is the guy who talks in other people's sleep. So I have to be as lively as I can. Well, shortly after the Second World War, the eminent mathematician Norbert Wiener drew upon the Greek word kybernetes, meaning pilot or governor, to coin the word cybernetics, which he defined as the science of communication between people and machines. And as a derivative of cybernetics, cybermedicine is my word for the use of the computer to enhance communication in the field of medicine. Computing that can improve the quality of medical care while reducing the cost and actually, insofar as possible, improving the relationship between doctor and patient. Now, by way of a bit of background, I arrived in Princeton as an undergraduate in 1951, which was an exciting time in that small New Jersey university town. Abraham Flexner had recruited Albert Einstein to be the first professor in his Institute of Advanced Study, and which was, although not formally related to the university, was close in proximity, both intellectually and geographically. And among the other luminaries at the Institute was the great mathematician John von Neumann, whose groundbreaking ideas about the digital computer, formulated in part with Alan Turing, engendered great excitement and great expectations. And as a student bound for medical school, it occurred to me that the computer might have a place in clinical medicine. Well, I kept this idea with me into medical school, along with ideas about the paternalism I observed in hospitals. Patients were expected to comply with doctors' orders, a paternalism that seemed to me to be depriving patients of the right to participate in medical decisions. And I carried these ideas with me to the University of Wisconsin in the early 60s, where after my internship and residency in neurology in 2 years as a neurologist in the Air Force, my colleagues and I had the idea that we could, with a focus on the patient, that we could program a computer to interact directly with a patient, to engage in meaningful dialogue, to explore medical problems in detail, and to do so in a dignified, personalized, and considerate manner. Now, there was a theoretical reason for pursuing this. Could the computer actually model the clinician as an interviewer? But there were practical reasons as well. The time-honored method of taking and recording medical histories had serious problems for the busy clinician in those days as in these days. And I hope that the computer would help the doctor in the care of the patient, that using the computer would be interesting, perhaps even enjoyable for the patient. And in the back of my mind was the idea that the computer might actually help patients to help themselves with their medical problems. Now, the idea was controversial for its time, and a commonly asked question was, Warner, will your machine replace the doctor? Well, and a rejoinder that I found useful then, borrowed from educational psychologists, but I would submit still up to date, was that any doctor who can be replaced by a computer deserves to be replaced by a computer, because after all, we're primarily interested in helping our patients get well. And whatever will work should be pursued. I continued also with my ideas about the patient's rights into a set of ideas that in the vernacular of the 60s I called patient power, arguing that patients who want to should be encouraged to participate with their medical decisions and helped to do so. George Bernard Shaw once wrote, "Do not necessarily do unto others as you would have them do unto you. Their tastes may be different." There's, I think, wisdom there. I also suggested that the medical chart be, at long last, declassified, back in the 60s, declassified, shared, and when appropriate, developed jointly by doctor and patient. These ideas were also quite controversial for their time, but it would turn out that I was able to implement my ideas about patient power through the computer interview, because everybody, even though a computer taking a medical history was quite controversial, everybody agreed that if a patient were going to be interacting with a computer, the patient should be in charge. Well, for our early studies, we would turn to the Laboratory Instrument Computer, or LINC, which was developed at MIT by Wes Clark and Charlie Molnar, a powerful machine for its time, and in many respects the forerunner of the personal computer of today. Honey, can I have the water? Thanks. Mouth's getting a little dry. Thank you.
It's that time of year.
Yeah. Excuse me.
Not yet.
Well, one of the first patients to take our medical history, computer-based medical history, had been selected by an intern who was tired. He'd been up all night, and the idea of being replaced by a computer had a certain appeal. Well, I walked with this gentleman over to the neurosciences building where the LINC was housed, and he sat, they gave me, although to program the machine it was late night, early morning. Since I had a real patient, they gave me prime time. And I sat this gentleman down at the computer, spun in the program, turned down the lights because the dim characters on the screen were easier to see in the dark, spun in the program from tape, and turned back, I pressed the start button and turned back to observe. And the tapes churned, and after a few instructional screens, "Have you ever had hives?" appeared on the screen. Now the characters flickered, the lights on the console flashed on and off, and the link speaker emitted an eerie, high-pitched sound. And on the other side of the sheetrock partition, people were walking in and out, and an experimental cat was meowing. It was somewhat like Kafka's Castle or Arthur Kessler's Darkness at Noon. Clearly not optimal circumstances for a medical history of any type. And yet my patient became quickly engaged, and soon it seemed apparent to me that rapport had been established between patient and machine. And he talked out loud at some of the questions, and he laughed out loud. At some of them I meant to be funny, some I hadn't. And it was clear to me that for the first time in his experience as a patient, he was in charge. Here was patient power at work. And later, when the teletype machine, our printer, all caps, 10 characters a second, powerful for its time, printed out his summary in a legible but otherwise traditional format, he turned and said, "May I read that?" And of course, I felt that he ought to have the right to read it. And so there, in a break with tradition, he read his own medical record and discovered problems that needed correction. And over the years with our research with patient-computer dialogue, patients have been very, very helpful in revising and improving the quality of our interviews. Well, among the 50 patients to take the first medical interview, a history of allergies, the computer detected multiple allergies that nowhere were recorded in the patient's charts. And this was the inexorable reliability of the machine as I asked her a question, including in the lower right hand, the one, that's a penicillin allergy. And this is the way the question looked. Have you ever had an allergic reaction to penicillin? Well, we were encouraged by the early results. We pressed on with further studies of computer interview in a wide variety of medical and psychological problems. And in doing so, we did our best to enhance rapport and also to yield as much control as possible to the patient taking our histories. And this was in the 1960s at the University of Wisconsin. So if you were a student there and the computer asked, "Are you a student here at Wisconsin?" you said yes. The computer, I had it responding with "right on, power to the people, free Angela Davis," which was very good for establishing rapport. And we also did our best to yield as much control in the tradition of patient power to the patient as we could. These were the methods of yielding: requesting permission to proceed, providing sufficient information, respecting the patient's priorities, offering alternatives through the pathways, respecting the patient's right to decide, respecting the patient's right not to decide, and helping with uncertainty, and then respecting a reluctance to respond. And we also, at the time, I wanted to back up. Oh, I'm pressing the wrong button. Well, I'll press on. The results of that first study were published in the New England Journal of Medicine in January of 1966, and some years later. It was very gratifying because Franz Engelfinger, who was then the editor of the New England Journal of Medicine, told me that this was the first article in the New England Journal, Computer-Based Medical History System, the first article about clinical computing in the New England Journal, and that was very gratifying. We also...
Give you credit for that.
Thank you. We also did, as the second part of the medical record, developed a program for doctors to enter the results of their physical findings, and the doctors found this to be quite helpful, and we published in the Journal of the American Medical Association, and with a comparison between the doctor's handwriting and the computer summary. A little unfair. Our son Charlie, who actually my granddaughter Caroline is a guest of mine, and my wife Carolyn, and Caroline's dad is a writer, but he did cartoons for my book, and he pointed out that announcing the only foolproof, guaranteed, indecipherable, absolutely confidential record is DocScript.
Absolutely. Oh my God, it's so funny.
Well, in 1970, we moved to Newton, and I was offered a position at Harvard Medical School and Beth Israel Hospital in the Department of Medicine to join Howard Bleich with the support of Howard Hyatt and Mitch Rabkin. And Howard and I wanted to have a division of clinical computing, analogous to the other divisions in the Department of Medicine. But we knew that if we went through administrative channels, there'd be only two possible responses. The more likely would be, no, you can't. And the second would be, we'll form a committee, which would probably still be standing. So we took a strip of cardboard and wrote out Division of Clinical Computing and hung it outside our small cubicular offices. And sometime later, the medical center hired sign renovators who marched through the center like Costa Rican cutter ants. And when they came to our sign, they said, this will never do, and replaced it with a metallic plaque. Division. Now, as I've told my students over the years, this can be a very effective strategy, but one that should be used judiciously, maybe once or twice in a lifetime. Well, within our division, we continued with research with patient-computer dialogue, including a computer-based healthcare interview for hospital personnel, which we made available on terminals located throughout our hospital in years to come with our hospital-wide clinical computing system. And this particular interview, all hospital personnel with a password could use this, and that contained a general medical history, nutrition history, exercise patterns, habits, safety, environment, and stress. And for example, under stress in the past month, have you felt sad, discouraged, or hopeless? Now, if you think about it, with yes-no type questions, there are three assumptions that are made very often in clinical dialogue. The first is the person knows the answer, like, for example, and it may be the person may understand the question, such as a family history, but being an orphan, not know the answer. So we put in a maybe or don't know uncertain response. The second is the person understands the question. And it may be a bad question, so we can focus on questions that are consistently being not understood and change them. Or it may be a good question beyond the knowledge of the respondent, and then that should be a contingency to branch out and explain the meaning of the question. And hence, don't understand. And the third assumption is that the patient is willing to answer. And it occurred to me as a doctor that patients should have the equivalent of a Fifth Amendment. That it should be up to us as clinicians to explain the reason why we're answering, why we're asking the question, and how answering might be helpful to them in terms of their health and problems. But it should be their right, ultimately, to skip the question. And now it's rather not answer. And it's used very rarely, but patients have had told me that they really like having it there. They appreciate the offering of this response. And if they do, if it's an important subject, the computer will branch out and explain again the meaning or the reason why we're asking this question, why it might be particularly relevant to their health. And here, if the person answered yes about sadness, when life seems like it's not worth living, it's often helpful to speak to somebody about these feelings. And then we wanted to help people who were feeling sad. There are several places where you could call at any time to speak in confidence about these feelings. And help is available at any time with the Samaritans or the emergency room, ways in which they can turn. And we hope that patients, while we protected confidentiality, we hope that patients avail themselves of these facilities. And the data were that some 42% of the patients, close to 2,000 patients early on, were feeling sad, and 6% actually felt that life, or within the past month, life might not be worth living. So we really felt we were doing a helpfulness here. And the majority of the respondents found the interview worthwhile. Most, when asked, said they preferred the computer to doctors or nurses in their experience. Of course, the computer was asking a question. If the doctor or nurse had been asking it, the responses might have been different.
Yeah.
But very interesting, when asked, did you sometimes want to tell the computer more than it asked, some 50% said yes. So we moved on to revise and enhance the interview. And then a number of the respondents want to avail themselves of the various facilities available to them. Now, early on in our experience, with a wide variety of medical histories in medical and in psychological areas, patients told us they found it easier to communicate with the computer than to their doctor about potentially embarrassing matters. And this is a finding that's subsequently been corroborated by many others. There have been quite a few articles published on this. Even when their doctor wanted to know, even when they wanted their doctor to know this information, the telling could be uncomfortable and seemed easier to communicate it to the computer interview. And we published that early, actually back in 1968. And when we did a study with potential blood donors, the computer-based interview of potential blood donors elicited more HIV-related factors in the health histories than either the questionnaire or the interpersonal interview in use at the Red Cross. And these were potential donors at the Red Cross, and the majority of them felt that they were more open with the computer. Now, it's long been my premise that the largest, least well-utilized healthcare resource worldwide is the patient or prospective patient. And type 1 diabetes being my favorite example, because if the physiology of the pancreas were such that the child with type 1 diabetes needed only one injection every 6 months, he or she'd be coming into the major medical center. But since the need is 2 to 4 times a day, it has to be done by the parents or the older child. And it's been my hypothesis over the years that the interactive computer is well positioned to help patients to help themselves. And years before the internet, we did a study for patients with potential urinary tract infection. This was designed for women, and the program consisted of a teaching program for the use of the computer general medical history, conditions for referral and referral if indicated, a history referable to urinary tract infection, a urine culture, and the computer taught the patient how to give a clean voided urine sample, a discussion of treatment, and then the patient, in tradition of patient power, the patient's choice about treatment, and then suggestions for therapy, and a return visit where the computer did a follow-up interview. And the results, a small sample, but 10 were referred by the program for further evaluation because of the seriousness of their symptoms. 35 decided to take the sulfasalazole right away, and 1 decided to wait for the culture, which turned out to be negative, a reasonable decision. And when asked, how has it been to decide for yourself about taking sulfa, the majority of patients felt that it was a good thing. Patient power and work. Now, my brother and I have he's a psychologist, close friend, and we have the world's smallest school of psychotherapy, soliloquy therapy. But we have data that indicates that talking aloud alone can be beneficial, and particularly when studied with and facilitated by an interactive computer, which, although not understanding what was being said, was informed as an interviewer and could encourage talking aloud alone. And we published the results in the New England Journal of Medicine. And I would encourage all of you, if you're having a problem, sometimes when you're by yourself, talking about it out loud, it's better than thinking about it quietly. It helps you to keep on course and can be quite helpful.
Did you write that
down? And of course, there is a complication of patient-computer dialogue. The John Chancellor Evening News back in the 70s, based on our article in the New England Journal, did a piece with John Chancellor interacting with the computer. And Bill Malden, the great cartoonist, picked up to demonstrate, seeing the article in the New England Journal, did this cartoon. Here, the patient's talking to the computer. The computer's becoming a little discombobulated, and now the computer's on the couch. And my wife, Carolyn, wrote to Bill Malden, great cartoonist, and he sent the original sign to us. It was,
sweet.
It was wonderful. Now, our most current interview is a comprehensive general medical history, which, when tested by, this is the ambit of the complete history. It has some 6,000 screens in it. It's the most comprehensive one I've ever written. Of course, patients only, there are some 235 primary questions that are asked of everybody, but then contingent upon abnormalities, it branches out to the other questions. And when tested over Beth Israel Hospital's portal patient site with a summary to the doctors, the patients were very positive about this experience, and they were doing it from their homes over the internet. And the doctors in our study, in particular, wanted to have the family history and social history available to them as soon as possible. So over our portal patient site, we put up a family history available to all patients affiliated with Beth Israel Deaconess Medical Center. And thus far, well over 4,000 patients have provided their family histories. And this is just a description of our portal system with Cybermedicine, the medical history in progress. And when we asked patients about their reaction to the history, the majority found it to be very respectful. And this is the way the summary appears: the high blood pressure, father, type 2, and then history -4, listing the negatives. Now, as a quick summary, the disadvantages of patient-computer dialogue, as I see them, are that it's less interactive to this day, artificial intelligence notwithstanding. Of course, you know the old definition of AI, real stupidity, but great progress is being made, I must say. But less interactive, insensitive to most but not all nonverbal information. And we did some studies. Here's this response latency with time to respond to questions, and goes up with age. I think in part because people have had more medical experience and they're giving more thought to the questions. And difficulty with free text and spoken words. Once again, less and less an issue. And of course, most important, lacking the existential human qualities of the interpersonal reaction. And one of our goals over the years has been to free the clinician up to spend more existentially useful time with the patient. That's been my goal. Now the advantages: reliability and consistency, automatic processing, economy, the patient does the data entry, anonymity when desirable, individualization without accusation. Sometimes if the doctor asks the patient, has she ever had, say, a sexually transmitted disease, wonder why does he think I might have, whereas with our interviews, people know that everybody is being treated the same. And endurance, the computer unaffected by fatigue. And then in terms of global health, it can be in many languages, and we've done some studies at the Harvard Street Clinic with interviews in Puerto Rican Spanish and Haitian French, very well received. And then the availability of computer interviews. Now, I thought, how am I doing on the time?
About 10 minutes.
About 10 minutes?
Yeah.
Perfect. Well, the second area of our interest has been cybermedicine for the clinician. And in the late 1970s, Howard Bleich and I received the mandate to extend our research from our laboratory to the day-to-day operation of Beth Israel Hospital, and then several years later, Brigham and Women's Hospital as well. And these hospitals then became our laboratories in which to design, implement, and study clinical computing designed primarily to help the clinician in the care of the patient. Sort of the other end of so many programs that start off as financial programs and then try to make them clinical programs as well. And our hypothesis was if we start off with the primary goal of helping the clinician care for the patient but saving the data, good things would happen financially as well. And the hospital-wide clinical computing, among the unique features of our system, Bob Beckley, Howard Bleich, our colleagues, and I, was that all data were stored in a common database shared by all applications with an audit trail kept for all users. So if there was been a change, you could check to see who had made the change. And what that meant was if a person appeared in the neurology clinic and changed his or her name, that was immediately reflected throughout the system on all terminals. And our clinical use, inpatient and ambulatory, first providing clinical information upon request, and here's an example of the scope, all labs, and then blood bank, blood gas, And virtually all of the clinical departments and labs that generated results we put up on our machine. Giving support with decisions, advice and consultation to the clinician, bibliographic retrieval, paper chase. Howard Bleich invented paper chase, the first user-friendly access to the Medline biomedical literature, a major contribution to medicine, heavily used, annotated, and very helpful to those who subsequently went on to develop PubMed and the other accesses. But Howard's was the first. And then searching the clinical database, Charlie Safran and our colleagues and I had a program we called ClinQuery, which enabled one to do searches of the clinical database. You could find patients, get a patient with an unusual constellation of symptoms. You could look for patients within our database with similar symptoms and see how they fared clinically. And also it's been very powerful for research purposes. And then offering alerts and reminders, and alert if there's a serious problem that needs immediate attention, or reminder that the person needs a vaccine, but it's not an emergency situation. And then assist with interpersonal communication. I think at the Beth Israel Hospital we had the first email system in any clinical facility in the country, or maybe in the world. We came up with our email in the late 1970s. And one feature that we found very helpful, if you sent a message in anger and it had not, you could inquire if it had been read, but if it hadn't been read, you could retract it and experience the benefit of a psychological catharsis while not suffering the diplomatic consequences. And as an erstwhile neurologist, I used to say I was working on how to retract it once it had been read. But I think you'll all agree that fortunately we haven't been able to do that. And then assist with clinical practice. For example, assisted with requests, we did order entry, assist with administrative chores, report adverse drug reaction, cross coverage for the house staff, personal patient lookup so you could have a cut, your own patients in a record, and then help for the medical students and residents as to their clinical experience. And then confidential counseling for the house staff. That was used quite heavily. The house staff, one of my causes have been to reduce the sleep loss in training, and we've had success. But also if a resident is feeling depressed, we wanted to offer help for that person, and that was utilized as well. And then assisted with education, and in the tradition of John Dewey, learning by doing, cybermedicine promotes learning in the context of caring for real patients. Now, evaluation. I think these criteria remain to this day. First, years ago, Thorndike, Watson, and Skinner taught that behavior is shaped by its consequences. If the consequences are reinforcing, the behavior is strengthened. If not, the behavior disappears. And when we came up with our system, our users were all voluntary users, which isn't the situation today. But we were in a position to see the extent to which we were reinforcing the behavior of use. And we could assess the strength of reinforcement early on because use was voluntary, and a distinguishing feature was the intensiveness and extensiveness of use of our system without coercion. And you can see when we started studying in 1984 and 88, the number of lookups of patients in a week. You can also see the trend toward more and more outpatient care.
Yeah.
And here's a breakdown on the individual labs and the extensiveness with which the program was used. This was very gratifying. And then attitude towards the system. I wrote a questionnaire for the users, and with a computer-conducted interview that we attached to the program, of 849 polled, 662 responded, or 78% found. 78% responded, and 89% found the system to be very helpful. And a resident doctor at Beth Israel Hospital wrote, "If we'd had the system when I was an intern, I estimate that I would have saved myself an hour a day at least." And a doctor at Brigham and Women's, "This has been a very helpful service, has added to our ability to provide good care, communicate, and been a real time saver as well." And then the educational power of the system. This a senior resident at at Beth Israel Hospital wrote, "The system allows you to deliver much better patient care and do everything a doctor does much more efficiently because you have such quick, easy, and reliable access to test results and other patient information. But the patient is also a tremendous teacher. It allows you to follow up all you want on your patients. It's probably the single most used thing in the hospital." And there were a number of, many of these testimonies, very gratifying. And then the effect of the system on quality of care. This is the most difficult, of course, but computing that offers information requested and advice on how to use it with more ease, speed, reliability, and accuracy than otherwise possible is improving the quality of care. I'm stating that as a premise. And then we did find, as have others, that the time to act on important clinical events is significantly reduced when the doctor is reminded or alerted by the computer of the need to act. And we found that at Beth Israel Hospital, and David Bates at Brigham and Women's Hospital also using our system. So doctors at Beth Israel Deaconess Medical Center acted more quickly when offered reminders and alerts about procedures and medications. And then cost of the system. When we developed ours at the Beth Israel Hospital, the cost was about 1.5% of the operating budget, and at Brigham and Women's Hospital, where we did the financial computing as well early on, and that was 2% of the operating budget. This was done through the 80s and early 90s. And the effect of the system on hospital finances, it took me, here, these are the days to collect funds that are due, and you can see at Beth Israel Hospital, as we brought up the different systems, the time to collect went down substantially. And this was true also of Brigham and Women's Hospital. Very gratifying. The chief financial officers were very pleased. Now I have a theorem that the quality of computing is inversely proportionate to the size of the instruction manual. Or I would add the length of the training period required for its use. And the electronic medical record systems are now supervised by administrators at both medical centers, and they've been moved to new web-based technology. But the principles of clinical use and evaluation remain valid, I would submit. And my hope for the future is that clinical informatics will become more and more helpful and less time-consuming for the clinician, who will be free to spend more and more time with the patient. And here are some references, and thank you very much.
Ask questions from the audience, so please, if anyone has a question,
I'm in the first row for a reason. Thank you so much for the presentation. In the late 70s, I worked in a community hospital, and I had to look at records like when you showed the slide with the handwriting and the computerized data. I had to use that handwritten data, and it was so hard to use. I would look at the progress notes, but I relied on nurses' notes to find out what was happening to patients. But now I waited 30 years, and now we have electronic records, and I want to thank you so much for all that you've done to help bring us to this place where we can really enjoy ease of use, better outcomes, everything that comes along with using electronic medical records.
Well,
So,
thank you for those very kind words. I really appreciate that. And it bothers me. There's a tendency to assume that there's one electronic medical record, and sometimes you read in the New York Times or Wall Street Journal that electronic medical records aren't necessarily living up to their potential or things like that. And it's almost like saying syringes aren't living up to their potential without knowing what's in them. And I think as far as the future for all of you, and I'm counting on you as an octogenarian, is to work to make the computing more and more user-friendly, more and more attention to the human factors, the interaction, try and avoid features at the expense of functionality. With a new word, I have trouble finding double spacing, for example, because it's buried within all sorts of marginal control, which may be helpful, but I think that in the future, this will be a major vector, having the computing be more and more helpful to the clinician in the day-to-day practice of medicine.
and the patient.
Of course, with the patient. Patient power.
Yes.
Any other questions?
Do you think that the AI interfaces that we have now in our home, the Alexas, the Google Homes, do they make it too personal? In your experiments, it sounded like the computer added a level of anonymity and a level of separation from being of confession, right? Are those still confessionals, or are those too personal?
The question is how useful and how intrusive are such new programs as Alexa in the home? And such an excellent question. I did another talk recently. I wrote it. E.M. Foster back in 1909 wrote a short novel called The Machine Stops, where with remarkable prescience, his only venture into science fiction, but people were living in underground in one person per hexagonal room, and all their needs and desires were provided by the machine. Yeah. And there was less and less need to leave the room. He didn't anticipate artificial insemination, but apart from that, everything was brought into the hexagonal room. And then there comes the pivotal point where no one person understands the machine in its entirety, and then the machine is sort of in charge. Yeah. And people start worshiping the machine, praying to the handbook, and then one day the food doesn't taste so good, and the lights are dim, and the bed doesn't rise up when it's needed, and the machine stops. Well, Foster leaves room for hope because one of the heroes has ventured forth and has seen some human figures off in the distance. But he wrote this in 1909, in the dawn of electricity. Wow. It's a long-winded answer to your beautiful question, but I think it's going to be on our shoulders and our descendants' shoulders to decide what we want to automate and what we don't. Norbert Wiener once wisely admonished, render unto man the things that are man's, and unto the computer the things that are the computer's. But of course, the real dilemma is where to draw the boundaries. At what point does automation dehumanize? At what point does virtual reality destroy real reality? And these are the questions that we're going to have to face as we strive, as we must, to preserve our essential human qualities, our human nature, our humanity.
Beautiful.
Question back there.
One comment. I don't know if people here are familiar with the Black Mirror series.
Oh, yes.
Right?
Yes.
So basically this extrapolates upon this theme wildly, right? That it's near reality. It's like the Robopocalypse book, right? Okay? It's near world potential. So it's very interesting because I think that as we see in our own children how their relationship with technology is dramatically different than our own, right?
Yes.
Then to extrapolate from another generation, how does that impact on, say, these subsets like the physician-patient? It's a good question.
Such a good point. Hey, well, you all have been great. Thank you.
You've been great.